All right then. Welcome everyone, and thank you for joining us for this Kerby Center's fourth presentation in our month-long series of presentations on infectious disease, immunization, and staying healthy in mind and body, powered by Sanofi Pasteur. And as we gather here today, it's vital we remember the peoples who have gathered here for millennia. This is the Treaty 7 land of the Indigenous peoples of Southern Alberta, the Blackfoot Nations of Siksika, Piikani, Kainai, and Tsuut'ina First Nation, the Stoney Nakoda Nations of Chiniki, Bearspaw, and Wellesley, and the historic home of the Northwest Métis and Métis Nation of Alberta, Region 3. It is with the goal of reconciliation that we acknowledge the land on which we gather, and we thank the elders of these nations for their timeless contributions to this land. And we know that the past 9 months have been particularly difficult time for our seniors, and many of you have had genuine concerns about how to lower your risk and maintain good health in the midst of the pandemic and upcoming flu season. Over this past month, with the support of Sanofi Pasteur and several renowned medical professionals, we hope to have answered some of your questions for you and provided you with the information that you need. We're very excited this morning to have such a distinguished panel of medical professionals who will give an update on COVID-19 and the various infectious diseases that impact older adults, and to provide you with the information resources on the immunizations that you need to stay healthy this season. I'm very pleased to welcome back Dr. Mili Stanichuk, who is the Medical Science Liaison Western Provinces for Sanofi Pasteur Canada, specializing in immunology. Dr. Stanichuk presented during our October 1st presentation, and we're happy to have him join us today as moderator for our presentation and panel discussion with Dr. Jai Hu, Dr. Mary Szabo, and Anjli Acharya. Dr. Hu will be joining us a little bit later as we get started. And now I'm going to turn it over to Dr. Stanichuk. Thank you.
Thank you very much, Colleen, and welcome everyone. Thank you again for inviting me back. I'm honored to be part of such a great event again with the Kerby Center, and I'm happy to moderate. We have some great experts here who are really going to share a very diverse and a comprehensive overview, as Colleen mentioned, to continue the immunization conversation, and in particularly during this year to really put it in the spotlight and to provide you all with the most up-to-date information. So I won't go on too long. I will pass it over to Dr. Szabo. So Dr. Mary Szabo is a family physician and clinical associate professor at the University of Calgary and has an extensive career practicing in Saudi Arabia, Pacific Island, and even Ontario. Dr. Szabo will help us understand the risks, complications, and the impact of influenza and COVID-19 on older adults. I'll pass it to you, Dr. Szabo.
Great. I'm just gonna try to fix my screen so that you can see it. Can you hear me?
Yes.
Okay. So, okay, can you see the screen?
Yes.
Okay, great. So thank you very much, Miles, for the introduction, and good morning, everybody. It's a cold, wintry day. So as you can see, that winter is coming, and the upcoming flu season is actually really around the corner. So with this year is quite different because with COVID-19 pandemic is still unfolding, and there is actually enough evidence to show that we're in the phase 2 of the pandemic. Public health officials actually are quite worried that there might be a thing called the trendemic, in which there are both diseases causing illnesses happens at the same time. Now, if this happens, this have great impact on our senior. So I would like to have a quick overview of influenza. There are 3 strains of influenza. Human influenza type A and B causes seasonal influenza epidemic. Type C is actually really very mild, and so it's not thought to cause us to have any kind of problem at all. So there's some facts on influenza. worldwide, globally, there are 1 billion cases of influenza, with about 3 to 5 million cases of moderate and severe flu-related illness. And it causes about 300,000 to about 600,000 deaths globally. Now, in Canada, we have about 40,000 of laboratory confirmed cases. However, this number is really markedly underestimated, as most of the people who have the flu actually do not seek medical care or have themselves tested. So every year we have about 12,000 hospital admission, which is related to the flu, and about 175,000 flu-related emergency visit, and it costs us on the average of 3,500 flu-related deaths. So influenza is not only a highly contagious respiratory disease, but it also causes a direct and indirect complication. The direct complication is mostly with respiratory effects. So you can see that it can cause exacerbation of asthma or chronic lung disease. It can also cause ear infections or sinus infection, and it can cause infection and bronchitis in the lungs. And in some cases, it causes the gut infection, producing symptoms of diarrhea, nausea, and vomiting. However, there are indirect complications of influenza as well, which affects other organs. So you can see on the right side that influenza can trigger off a heart attack. It can actually also cause muscle injury of the heart, a condition called myositis, and it can cause congestive heart failure. It can trigger off a stroke. And if you have chronic kidney function and diabetes, influenza can make these conditions a lot worse. So as you can see that, this slide shows that in terms of if you have chronic diseases, if you have heart disease, you have a 5 times higher risk of dying from influenza. And if you have lung disease, you have a 12 times higher risk of dying from influenza. But if you have both, that number increases quickly to about 20 times. So it is really important that we need to prevent influenza with people who are high risk for developing severe disease as well as its complication. So why is the population in Canada, the senior population will account for about 15 to 17% of the Canadian population. But you can see that hospitalization due to flu-related illness, 70% is actually from the elderly. And the seniors also account for about 91% of influenza-related deaths. Okay, so this slide sums up why influenza is not taken very seriously. As you can see that the number of lab-confirmed influenza is really just the tip of the iceberg, with majority of the people with influenza actually never seek medical help or get tested. A lot of the people who perceive that influenza is actually a nuisance. It causes, symptoms like fever, headache, muscle ache, cough, or sore throat, which actually will resolve itself in about 7 to 10 days. However, the non-respiratory complication of influenza, such as heart attack, stroke, pneumonia, will actually remain unknown or unaccounted for. So in this case, it is true that influenza has a medical, economic, and society burden, which are not well appreciated. So let's go quickly on COVID-19. COVID-19 is a really new kids on the block. Like influenza, it is a highly contagious respiratory disease, but it's caused by a different virus. It's caused by the SARS-CoV-2 virus. So the WHO actually declared COVID-19 as a pandemic in March of 2020. As of to date, there are about 40 million confirmed cases worldwide and more than 1 million COVID-related deaths. Now in Canada, as of today, we have about 200,000 confirmed cases with about 98 COVID-related deaths. Okay. So this slide shows that, how the virus is being transmitted. So COVID-19 virus has a zoonotic in origin, meaning that it comes from animal and then it jumped species and actually started to infect the human. So if you actually take a look at the phytogenetic of the virus, which caused COVID-19, genetically is actually related to the SARS-CoV-1 virus, which causes SARS, as well as 2 strains of coronavirus, which was found in bats. So this is the reason why a lot of experts believe that the origin of the virus actually comes from bat. It gets mutated, and it was jump species to infect the human being. Transmission of the SARS-CoV-19, COVID-2 virus primarily occurred in the direct transmission through respiratory droplets. And these droplets are produced and generated when a person coughs, sneeze, or talk very, very loud. And someone who's very close to the infected person will have the droplet landed on their eyes, their nose, and their mouth. Now, aerosol transmission in COVID-19, there is increasing evidence that it does play a role in the transmission of the disease. To a lesser extent, that the disease can be transmitted by touching surfaces which is highly contaminated. So this is a clinical manifestation. If you can see that the initial presentation, the symptoms, these are very, very similar to influenza. So based on clinical manifestation, it's almost impossible to distinguish influenza and from COVID-19 without being tested. So, the estimated incubation period, meaning that the time in which from exposure to the time of symptoms can, for COVID-19, it can take as long as about 14 days, but the medium incubation period is about 4 to 5 days. My slide doesn't want to move. Okay. So this is the disease spectrum, which is really very, very interesting. So you can take a look at the bottom of a majority of the people, I would say, would have about pretty well subclinical, meaning that they don't have disease, they have infected, but they don't have the symptoms yet. Okay, so those are called preclinical. But quite a few people who have the disease but never ever develop any kind of symptoms, and they are called asymptomatic. So the base of that, there are quite a few people who infected COVID-19 belong to that category. Now, the disease spectrum can ranges from mild disease, which account for about 81% of the time, to moderate disease, which are more severe and it required hospitalization, to severe critical disease in which these people actually would need admission to intensive care, and the worst thing is death from it. So the recovery course is really very variable. It really depends on the severity of the disease, depends on the patient's age, and actually morbidity. So early studies from China shows that it takes about 2 weeks for people to recover from mild disease and about 3 to 6 weeks for severe disease. However, as the pandemic unfolds, there are lots of people who have persistent symptoms after COVID-19, and some people actually states that they never return to the baseline health. Now, these people are mostly elderly with multiple comorbidity. However, 20% of the healthy individual also claim that they never come back to the healthcare baseline health. So this is to show that COVID-19, just like influenza, besides causing a direct effect on the lungs, it also causes problem in other organs. It can trigger off a heart attack. It can injure your heart muscle and causes heart failure. It can also cause your heart to come out with a very irregular rhythm. And it also causes clots in the artery, which could cause you to have stroke or lung clot. And infection the virus also causes an exuberant response, systemic inflammatory response, causing organ failure, etc. So who exactly get COVID-19? Almost anybody can get it. Anybody of all ages are at risk for getting the disease. However, the probability and the risk of getting severe disease, as well as complication for COVID-19, are mainly in the elderly. So the burden of COVID-19, you can see that the number of hospital admission related to COVID-19 are usually in the elderly age group, and ICU admission also reflects that. So this confirms that, senior 65 and over carries a large burden of disease. So disease burden, this is death, and this is actually frightening. If you take a look at the graph, senior accounts for over 90% of the COVID-19 death. And this is very, very similar to influenza. So this slide is really interesting. I took it from actually CDC. If you take about the comparative age of 18 to 29 as a comparison group, people younger than that has a lower risk of hospitalization and a lower risk of death from COVID-19. However, when we get older, this risk increase. And by the time that you hit about 65, you are 5 times higher than this comparative group in getting hospitalization. And your risk of dying is frightening, that by the time you're 65, you stand at 90 times higher chance from dying from COVID-19. And when you hit 60, 85 plus, that risk jumped to about 630 times. So these are the risk factors which can increases your transmission and your risk of getting disease. Crowded condition, without social distancing in an enclosed place, as well as actually duration of exposure. And what you can do to mitigate or reduce your risk is maintain your social distancing. And when it is not possible, please wear a face mask, frequent hand washing, and cleaning with sanitizer. So this slide is, as we know for a fact, that the percentage of patients who die from COVID-19 is 12 times higher, and the percentage of patients who are hospitalized is about 6 times higher for COVID-19 in patients who have at least one medical condition. And majority of the highest age group are people over 70 with medical condition. I put out this slide. This is actually published from CDC, and it shows you that people who have a co-infection of influenza and pneumonia as you go increases in age from 65 and over, you can see the number of cases increases. So that goes to show that, co-infection can have a major effect from both disease and increases mortality in the senior. So why is it senior is so vulnerable? As we grow older and smarter, our immune system is weakened. And so this process is actually known as immunosenescence. Because of the weakened immune system, it will predispose us to any kind of infection, influenza, COVID-19, and it can cause us to have severe infection leading to increased hospitalization. As we grow older, we also have increasing prevalence of underlying medical disease. And these, when will constitute an increase in hospitalization, even death, because these disease, influenza and COVID-19, also have a complication involving these chronic disease. As we grow older, we're more frail. With hospitalization, what it does is after hospitalization, senior has a much longer road of recovery, and most of, if not many of them, have reduced autonomy. So it really robs them of their autonomy. So quick thing about how vaccine works. So vaccine is actually made out of kill weakened virus. It cannot give you the disease at all. However, it actually mimics the disease agent, and it actually primes your immune system against future attack. So as a result, you gain future immunity against the virus without actually getting sick. So the impact of influenza on seniors is that the bottom line is seniors are high risk for severe and complication for both disease. And the risk of co-infection is high for senior because of immunosenescence. And it carries a high disease burden for both disease. Bear in mind that there is right now absolutely no vaccine or treatment for COVID-19. So it's very important for the senior to get their vaccination with the right vaccine in order to reduce influenza during this period. So the take-home message is very similar to the previous slide. Senior at high risk for severe disease and complication from both disease. And we carry a very high disease burdens from both. Co-infection is actually absolutely disastrous. So getting a flu shot for yourself, your loved one, and whoever cares for you is very, very important during this flu season. And this might be, as I say, your most important flu shot ever. And that's it. Thank you.
Thank you very much, Dr. Szabo, for that very comprehensive overview of not only COVID-19, but of course, influenza. Some very interesting studies and some compelling evidence. And I, again, really appreciated the nice, clean take-home messages for everyone. So I encourage everyone, if they have any questions, to post them in the Q&A box. There is a comment here, perhaps Dr. Szabo, you can speak to it. The comment is, typically wearing face masks cover the nose and down to the chin. If droplets affect the eyes, then face masks are not fully doing their job.
That is really correct. There is actually a study done in China very early on comparing people who is infected with COVID-19, those who wear glasses and those who doesn't wear glasses. So the study shows there's a very small population of the patient, and they seems to, as a result, they think that wearing glasses might protect you. So, but the thing is the role of, contact through your eyes are not really, how would I say, documented, but I always wear my eyeglasses, okay? But wearing a face mask has been shown that it will reduces at least about 15% of the transmission. So you can see a lot of people actually wearing a face mask as well as a face shield. And so, so the study are very limited in causing that, but theoretically, because the eye has a mucous membrane and the virus can land on the mucous membrane and get into the body system.
Great.
Hopefully
Thank
that
you.
will answer the question.
Absolutely. Thank you. We have a few more here. One from Shivani. What do you think about the rapid testing with swabs and at-home testing kits? Is it reliable? And the second part is, what are your views on spit tests?
That's an interesting thing. In Canada, I think we're still using testing. Now, if you want to talk about testing, I would classify as two types of testing. One is high and clinical analytical sensitivity. These are the tests in which we do the throat swab and the nasopharyngeal swab, and it required a special lab. Okay, so those in terms of technically is very, very sensitive in terms of that, but it's very laborious. The rapid test, on the other hand, is quite different. The rapid test, what they do is their job is only to detect the presence of the viral particle. So theoretically, they are not analytically as sensitive as the other tests that we use right now. Is it sensitive? Yes, it is sensitive, but the thing is, it's not as sensitive as a usual test, okay? What it does is the rapid test depends on the viral load. So if you have initially infected with COVID-19, the viral load is very, very high. And so the sensitivity test will actually picks it up. But what makes the test important is actually the sensitivity of the testing regimen. What I meant by that is this: if you use the rapid test, but you test the person more frequently, okay, 3 to 4 times a week, what you're able to do is you are able to pick up cases in the very early on the disease, which are very, very infectious. And it would be able to identify those individuals. Now, for the high sensitivity, the throat swab and all these kind of stuff, if you don't test them vigorously, a positive test means two things. Either you catch the person very early on, or you catch the person at the tail end of their infection when they're no longer infectious. So a positive test with the high sensitive test doesn't mean that you're infectious, but it just shows that you have viral particle. Saliva testing, there is an article published in New England Journal of Medicine to say that they are just as compatible as a swab. So, right now we go with the flow, and I do hope that the rapid testing will come in. And I think if one utilize a high sensitive testing screening regimen is important. Hopefully that will answer the question.
Great, thank you. And just one more quick one, Dr. Szabo, from Chris Hayes. How safe do you perceive traveling by airplane commercially?
Yeah. Well, everybody say, I don't travel right now. And I said to all my patients that the highest risk of actually getting COVID-19 is while they're in airport and mostly in the airplane, because airplane is a closed environment. And so their study actually by CDC actually show your highest risk of getting COVID-19 is to have someone who's infected with COVID-19 sitting right next to you, or a row in front of you and a row behind you, okay? If you are further away from the index cases, it is, how would I say, lower risk. My advice for all my patients is please wear your mask when you get in, wipe down the surfaces, frequent hand cleaning. All right. And that if you cannot have social distancing and you don't buy a whole session of the airplane like some of my patients do. When they travel, they just buy up a whole session of the airplane so that it's just 2 of them. So if you don't have that option, wear your mask, clean the surfaces, and frequent hand washing. Okay.
Great. That's great. Thank you again, Dr. Szabo, for that presentation and for answering those questions. Maureen, I do see your question here, but I think it will be addressed with Dr. Hu's talk. So the question is, do you anticipate fewer cases of influenza due to the use of masks this year? So I think that will probably be covered in Dr. Hu's talk, which thank you, Dr. Hu, for joining. So I'd like to welcome and introduce Dr. Jia Hu. Dr. Hu is the Medical Officer of Health with Alberta Health Services in Calgary Zone, and will give us an overview of Alberta Health Services immunization program and what to expect with COVID-19 and influenza this season. So thank you again, and take it away, Dr. Hu.
Great, thank you, Mile. I think, Colleen, were you going to drive my slides a little bit?
Yes, I can, if you're ready, I'll just do the share screen, get that up right now.
Yeah, for sure. Oh, just on the airplane thing. So we actually spent some time digging around data within Canada. So for the months of June and July, it's kind of funny. We like BC, Alberta, Ontario, and the federal government were aware of 2 within flight transmissions, both on the same flight, both into YVR, and during those 2 months, there's sort of 5,000 inbound flights to YVR, let alone all the flights to Calgary, Edmonton, Toronto, and Ottawa. And so I think the risk is actually pretty low. But as Dr. Szabo was saying, it is highly contingent on what I call the incidence of COVID at the point of departure. So if you're sitting on a plane full of where everyone has COVID, yeah, you're probably gonna get COVID. But in general, that's it's pretty safe, I would say, from that point on. I mean, there's a few other considerations, but there's quite a lot of air exchanges, 15 to 20, and we know outdoor transmission is 20 times less than indoor transmission, and a lot of that has to do with air exchange. So whatever, I think it's pretty safe, but lots of people are still scared. That's fair. Anyways, now let's begin. Thank you so much for putting this up. All right, next slide. So I'm a medical officer of health. I work for I have some other jobs. Next slide.
Next slide, sorry.
Yeah. And so we'll talk, a bit about COVID-19, what to expect this flu season, general preventative measures, and some influenza immunization updates. Also, because I was sort of late coming to this one, if there's anything that I'm covering that has definitely been covered, just let me know and I'll skip over it. So next slide. Yeah, so this is a graph of all the cases in Alberta, new cases by day. You'll see that, in April, we had a lot of cases, over 300, mostly in Calgary Zone. But now we're basically near the peak we were in the spring. That's mostly being driven by Edmonton, actually, this time around. But, are we in the fall second wave? I mean, maybe. But next slide. Yeah, this is just a quick breakdown of cases. We're going to highlight a few things. Edmonton, this bottom graph, the green, Edmonton has a lot of cases. Calgary has a lot of cases, and the other zones don't have that many cases. Sorry, AHS has 5 zones, just there's north, which is north of Edmonton. There's Edmonton, there's central, which is between Edmonton and Calgary, and then there's south, which is south of Calgary, essentially. We still see a preponderance of people, let's say, under the age of 40 in this top left graph here. A lot of, when they say unknown on this graph here, it just means it's somewhere in the community. And that's sort of how we characterize these things. Next slide. Yeah, so this is sort of a map of so Alberta Health uses classification, three levels: open, watch, and enhanced. So, you're basically open unless you hit watch, which is more than 50 active cases per 100,000. And then you hit enhanced if it's higher, and you actually do something about it. So you see all of Edmonton is in the enhanced level. Calgary, watch, again in the northeast, which is where Calgary's always had most of its cases, to be honest. Next slide. Yeah, so from now we talk more about COVID itself, but I think for the above 3 slides, be articulating the fact that we have a lot more cases now. I think our active case count in Edmonton is similar to Toronto's, and Toronto's gone pretty locked down, similar to London, England's as well, also pretty locked down. Alberta's pretty open still though, voluntary measures only. But we can blitz through this. I mean, COVID, we know that the mortality is highly variable, less than 0.1% probably in kids, greater than 15% in people who are quite old. Next slide. Yeah, basically in terms of its symptoms, very hard to differentiate from anything else, frankly, any other respiratory illness, except perhaps for the loss of smell and the loss of taste. But other than that, it's the same stuff, right? Like, and you can have pretty mild symptoms. You can also be asymptomatic. And so you don't really know what you got, whether it's influenza or common cold or COVID. Next slide. We can just sort of skip through this, disease factors. Next. Yeah, let's talk about transmission a little bit. I think this is pretty important. As the thinking around transmission has sort of evolved over time. I mean, the main mechanism is still remains, droplet and contact. If Millet has COVID and he coughs on me, like I may get COVID. We know there's a fair amount of asymptomatic or pre-symptomatic transmission. That is transmission that occurs. Well, the pre-symptomatic means like you'll get symptoms a day or two from now. And estimates of that range from like 10 to 40% of all transmission, but it's hard to quantify. And then, lately there is a small amount of what I'll call aerosol transmission, and that means sort of like airborne, but sort of like not, but it accounts for a pretty small proportion of total transmission, and conceptually, like if you had flu and if I had flu and then I'd like took a fan and blew behind me, it would probably carry the flu particles more than 2 meters. But we're really scrutinizing transmission mechanisms. One thing that is interesting actually is the fomite transmission, which is like, somebody coughs on a table with COVID, you touch the table, you touch your eyes, you get COVID that way. Like, I think that remains obviously conceptually possible, but there's yet to be like a single paper articulating only fomite transmission. And I think it's very hard to figure that out in a paper, but it may lend some credence to the fact that hopefully it's a bit less than, we thought it was. Also, PPE, highly effective at stopping transmission, right? And so, I think when this first thing came, like when this came and we saw like a bunch of these doctors in Italy getting infected, we're like, holy moly, we're in trouble. But, with good PPE, like it's very hard for somebody to get COVID actually. Next slide. Question came in to slow down. Thank you. I will slow down. Yeah, I talk pretty fast, sorry. There's no treatment for COVID-19 in an outpatient setting. I think there's, that thing Trump took, Regeneron, that I think is meant to be an outpatient treatment for mild COVID, but no peer-reviewed literature on it yet. It's a polyclonal antibody mix. And then they have some drugs they give you if you're really sick in the ICU, but you probably don't want to go up in the ICU anyways in the first place. So, I think some of these things mentioned here are really important. And, I think the distancing thing is quite critical. I think mask wearing has been quite critical, and just, limiting the number of social interactions that you have. Things that appear safer actually would be, outdoor type events. And so when the big Black Lives Matters protests happened in the US, I think, and in Canada as well, I think we were a bit worried about like more COVID emerging from that. Certainly there was a lot of crowding and not everyone was wearing masks, but there wasn't actually too much new COVID from those events. And so, like the perfect storm for COVID would be like, you're in like a poorly ventilated basement with like 10 of your friends or something. And so next. I'll talk really like briefly about testing. There's all sorts of tests that now are on the market. I mean, the mainstay remains that NP or throat swab, nasopharyngeal throat swab, pretty sensitive. So 91 to 98% sensitivity in our labs. It doesn't detect live virus, like it just detects virus dead or alive, which is why, we don't make people test negative if they test positive, because you can shed dead virus for many weeks after you're no longer infectious. We have serology testing available as well in the province, which looks for antibodies. You are identifying the presenter incorrectly. Anyways, there's
your photo has Dr. Stanachek's name underneath it for some reason.
Oh yeah, that's weird. Oh yeah, right. He sent me his link. All good. I'm Jia. Sorry.
Dr. Stanachek is joining us 3 times today.
Yeah. I like these questions. Yeah. Antibody tests, which are meant to sort of detect if you've been previously infected. I mean, the issue of reinfection is now bubbling up more and more. I think there's now been 2 proven reinfections in the world, and the evidence around like duration of immunity is quite mixed actually. So I won't comment on that, but for all intents and purposes, at least right now, the chance of somebody in Calgary having a reinfection I would say is extremely low. But as the time from the first cases starts widening, that may happen, but I wouldn't fuss too much about reinfection for the time being. Right now, at least. Next slide. Yeah, so testing turnaround times. Look, here's a practical tip. If you want your results as fast as possible, sign up for My Health Records. That is literally the fastest way you can get your test results, because it links directly into, it uses the same poll as Netcare does. And sometimes there's a delay after the test is processed by the lab to actually like get a robocall from HealthLink to tell you you're negative, or a call from public health to tell you you're positive. So that's that. We can skip, there's all sorts of other supports, but yeah, My Health Records, it's good. Everybody should get it, all Albertans. Next slide. Yeah, and this just shows, every day we do a few more tests than the day before. That's the top graph. Those peaks are sort of like probably like data errors. And then, our percent positivity actually is like inching up slightly. That means the proportion of tests that are positive, and it's still at around 2%, which is pretty good. But there's places in the US with percent positivities of like 40%, and that's really bad. But it is indicative of perhaps, more disease burden in the province. Next slide. Okay, cool. Let's talk about influenza. So that's COVID. Everybody's thinking about COVID. Everybody's thinking about respiratory viruses. Let's next. What's happening with flu this year? Hard to say, I think. Next slide. Yeah, so normally what we do is try to look at the Southern Hemisphere and Australia to see what our flu season might look like in terms of severity and predominant strains. And what happened, see, this red line here is the number of cases Australia reported in their season, which is like in our summer. And all these other lines are other years Australia flu season. And basically what happened is like peak lockdown coincided with maybe also the start of their flu season. And, the physical distancing, social distancing, it is very effective at stopping any virus or any infectious disease agent. And so we don't really know what the flu season will look like in the Northern Hemisphere. So, I think it won't be like this because we're not like locked down, but hopefully it also won't be like a full-blown flu season because we have some social distancing measures in place. Like people are still, people are wearing masks, as you say, people are probably not like going to, clubs or concerts or things like that. But, at the end of the day, we're going to have a season that's somewhere in between this and somewhere in between a regular flu season, the extent of which will be determined by, what I would call like aggregate distancing control measures, which is hard to, quantify. So that means we still should be quite worried about flu, I think. Next slide, please. Yeah, so I think in any given year that wasn't this year, when we had a global pandemic around COVID, I talk a lot, people would think a lot about, well, we try to really impart the importance of influenza prevention measures because, every year it does kill 3,500 Canadians. It's like one of the leading causes of death in Canada still. Next slide. It certainly kills or hospitalizes people who are over 65 a lot more than people who are younger. They over 65s make up maybe like a sixth or a seventh of the population, but they account for 90% of deaths and 70% of hospitalizations. So yeah, it's bad for you. Next one. And I think one thing about flu that people perhaps don't recognize is that I think we think of flu and COVID both as like respiratory diseases, right? Like they mostly like muck up your lungs and make it hard for you to breathe. But flu certainly can trigger all sorts of other events like heart attacks, strokes, those sort of like ischemic events. And COVID can too, right? We're seeing with COVID, there's like a lot of like hypercoagulability, which means, there's more sort of deep vein thromboses, pulmonary embolisms, but like these are all sort of like multi-system diseases. Next slide. And, for example, this paper from New England Journal basically says, 7 days after flu, you have a 6 times higher risk of having a heart attack than baseline, right? And I think people maybe don't recognize that, but it is part of how flu contributes to a lot of hospitalization and death. Next slide. So I guess to summarize, we don't really know what we're going to see this season, but I think we should be very cautious, right? Like one, it could be just a full-blown flu season. Like I don't think it will be, but like if it's 90% of a full-blown flu season, that'll be pretty bad. The other thing is, I keep on bugging Mealy about this, but I'm like, what data exists on like, COVID and influenza co-infection? And, because of that little Australia thing, we don't really have good data in that. Like, is it like just like having them both the same, or will it like synergize to make it even worse for you? And because we don't know that, I think it's quite important that we take the precautions against influenza that we can take. Next slide, which goes to preventing COVID. I think this has sort of been covered in the other, like the other thing with the nice little pictures. But, one thing I'll add is that people should get a vaccine. People should get a flu vaccine because it exists, it is available, and people should get a COVID vaccine when that becomes available. Next slide. These are actually just some interesting statistics around willingness to take COVID vaccine in Canada. And so with this basically it's from an Angus Reid survey poll done like September 25th, basically showing that only 40% of Canadians would get a COVID vaccine as soon as it was available. And another 40% would wait a while. And then 23% are like, won't/not sure. And so like, I like this is like, and I get why, I think there's a rapid pace of development, concerns around safety, Trump saying all this crazy stuff about having a vaccine before the election, regardless of safety. I mean, I will say this, like no pharmaceutical company will produce a vaccine that isn't safe. When they stop these big trials like AstraZeneca or in J&J for like one adverse event out of 30,000 like participants, that like demonstrates their commitment to safety. And similarly, while we may not trust the US FDA right now, like Health Canada, I think, is certainly still trustworthy, but at 40%, this is like similar to like flu uptake numbers, which is very bad. Next slide. And just, the people willing to get a flu vaccine, a COVID vaccine is actually going down. And so from the earlier poll, like same questions in July to September, 13% decrease in Alberta. So I think right now in Alberta, it's like 28% of Albertans will get a COVID vaccine if available. So very, very low. So anyways, everybody needs to get vaccinated, I think, when we have a good vaccine. Next slide. Yeah, we don't even, I mean, this is just illustrative, but it basically shows that, we talk a lot about herd immunity. One of the interesting things about herd immunity in a COVID vaccine is like the lower the vaccine effectiveness, like at 50% effective, the more people you need immunized to achieve herd immunity, like everybody, and it basically just depends on what you predict the R0 is. And so one of the difficulties will be, the less effective vaccine, the less likely individual people will get it probably. But the more people need to get it to create herd immunity. So anyways, things to think about. I think we are expecting interim vaccine trial results like later this month, actually, and in November. So, it's just around the corner, actually. Next slide. This slide talks about some of the facility-specific measures in terms of preventing like COVID influenza, but like, should I go through this or is this not as useful for the audience?
I think all information is useful at this point.
Okay, well, yeah, like I think that, Canada background had one of the highest mortality rates if you just look at like deaths over cases, certainly in the first wave of this pandemic, right? The reason for that was because we had a lot of people die in long-term cares, nursing homes, and other type facilities, especially in Quebec and Ontario, actually. Alberta and BC did pretty good. Since then, I think we've learned a lot about how to better contain COVID and influenza within these long-term care facilities, so fewer people die. And I think that some of the things that I'll like highlight, it's always the screening thing that happens, limiting visitors is akin to, limiting your social bubble. Continuous masking was very helpful. Identifying patients who were off as soon as possible and isolating them and testing them. And then even like asymptomatic sweeps to detect people who are in that pre or asymptomatic phase. And so I think now as our cases sort of go up in Calgary and Edmonton, we aren't seeing, like, we see long-term care outbreaks for sure, but we aren't seeing, like really disastrous ones. And I think that's because, a lot of the operators and, public health and healthcare aides have learned. But, as we head into the winter, like, I think a lot about these things because this is where people will die. And therefore, this is where we must stop, put in the measures to stop that from happening. Next slide. So I guess to summarize that piece, it would be like, get a vaccine. We'll talk about vaccines, but also some of those measures around how do you actually, and I can go in greater length around like the things I think that are the most important to prevent getting COVID or getting flu from those around you. It becomes quite like the things to think about, right? So that's masking, like not going to crowded indoor spaces, limiting your sort of social bubbles and your interaction space. And, really, another thing is actually staying home when you're sick. So we did an analysis of, Edmonton's cases about a month ago, and like 11% of those people had gone to work while sick. So that's pretty bad, right? Like, I mean, 1 in 10 is, I think before COVID, people went to work sick all the time. And, I think, back then we didn't recommend that, but now we really need to sort of not do that. And, there's things that'll support that, like the federal sickness benefit, which gives people actually sick leave, which I think is wonderful. But let's talk a little bit about flu vaccines. Next slide. So this just talks about the effectiveness. I mean, I think, there's a lot of misconceptions around flu vaccines. One of them is that like it doesn't work. One of them is that like, it'll give me the flu. And yes, the third one is like flu isn't that serious. And so in terms of whether or not it works, so like this graph on the y-axis shows how effective the vaccine is by year. And certainly there are years where the vaccine doesn't work that well, like 2014 to 15. But certainly there are years like 2013 where it was close to 70% effective. And so all in, I think we would say it's about 50% effective. And I think like it's not a measles vaccine that works 100% of the time, but this thing works, like reduces your risk, cuts your risk in half from getting this infection that at a minimum is going to make you feel really crappy, like with muscle aches and fevers. And, at a maximum for a lot of older people, it should kill you. So like, I think it's quite, next slide, important that people recognize the vaccine does work. The other piece around that is that the vaccine does tend to work better in people who are younger. So this again is like vaccine effectiveness on the y-axis by year, but then we have people who are under 65 and over 65. And you'll see that it always works a bit better in people who are under 65. There's something called immunosenescence where people a bit older, their immune systems can't react as well to the antigens in the flu vaccine. And so for everybody who's like, and this is, so you can't just be like, oh yeah, like, like everybody get the flu vaccine and I won't get it because like, I don't care. Like, it doesn't work as well in certain populations. And so when we talk about sort of herd immunity, cocooning, like it is important that everyone gets it, especially the young people, because, like, how does an old person get flu? By hanging out with other people who have flu. And so it becomes imperative that we all get the flu vaccine to prevent some of these adverse effects in the elderly, especially. Next slide. So coverage. So, in Alberta every year, about 30% of people get the flu vaccine. So that's pretty low. This year, I think the government has sourced, all governments have sourced a few more doses, anticipating that there'd be increased demand. But, at the end of the day, I think it's quite remarkable how low vaccine coverage is for the flu vaccine. And, it's a difficult sort of problem to crack. But I think it's important to remember that, like, even now, like, we do not meet any of our targets for flu vaccine coverage, like anywhere. And, it's a bit of a shame because, it's this like free thing that like might prevent you from dying. So, like, and now I think with COVID on the radar, people are thinking a lot more about respiratory viruses. And so they're probably maybe going to be a bit more inclined to get one. And I hope that increase in uptake, which I hope happens, like sticks. Next slide. What's in our vaccine? Basically every year the WHO meets and just sort of guesses. Guess is the wrong word. They use their data to sort of make estimates around what the most common circulating strains of flu virus will be, and they put that in the vaccine. And so there's a trivalent vaccine, which is like there's flu A, flu B. It has 2 A's and 1 B, and a quadrivalent with 2 A's and 2 B's. But these people, if their sort of estimates of what circulates is off, then you'll have a mismatch year and it won't work as well. But if they are more accurate, then you will have a match year and the vaccine will be more effective. Next slide. There's a group called the National Advisory Committee on Immunization, or NACI, that makes the recommendations on all vaccines, including flu vaccines. So these guys are pretty smart. Next slide, just so you know, that's where it comes from. There's a bunch of flu vaccines approved for use. Next slide. I'll talk a little bit about this. I mean, so actually, why don't you just go to the next one, actually, after this. So I think, one thing, like of the many types of flu vaccines, like you have what I'll call certain enhanced vaccine products, one of which is a high dose vaccine, one of which is a adjuvanted vaccine. And I guess you could think of another one being sort of like the non-egg based vaccine. But, a high dose vaccine is a vaccine where you just, if you normally put in one little vaccine particle, one virus particle in it, you put in 4 times that. And an adjuvanted vaccine is one where an adjuvant is something that is meant to sort of enhance your immune system. I think one of our only head-to-head trials comparing showing superiority between one of these enhanced products versus like the standard regular product is this study that basically showed that the high-dose vaccine had about a 25% more relatively was 25% more relatively effective than standard vaccine. And so, across the country, this high dose thing has not really been covered in Alberta, for the past several years. In different provinces, covered to different extents. But this year, Health Canada actually just bought enough high dose vaccine for everybody in long-term care, which I think, shows that they think it works better. I mean, I think it works better, but that's a good thing. And so next, and you can go back actually, one slide. It's okay if you can't, don't worry about it. Yeah, you can stay here, right? And so this is pretty interesting. So this is taken straight from the NACI recommendations, but essentially what they're saying is that if you're an individual person, a high dose is better than a standard dose, but at a population level, so they're all the vaccines are sort of the same. And I think they do this to help. How do I describe this? So the fact that the high dose is better than a standard dose, I think is demonstrated from that study that I showed on the next page. But at a population level, I think you need still population level data, and traditionally Alberta's only sourced, standard quadrivalent. But this year we'll have some high dose at least, which is good. Next slide. Next slide. Next slide. Yeah. So I mean, this just shows that it's more effective, and then there's different relative efficacies across different, age ranges and comorbidities. Next slide. I do want to focus a little bit on this. So in terms of getting a flu vaccine, so the public program starts October the 19th, which is very soon. And some facilities have already begun receiving the vaccine. Basically this year, because of sort of COVID demands, I'll say, everybody will be directed to get their vaccine at a pharmacy or their family doctor, if their family doctor does vaccinate. Except for people with kids under 5, and people with kids under 5 can go to the large immunization clinics. The reason for that is because pharmacists are not right now allowed to immunize under 5, and so public health big clinics for people with kids 5 years and younger. Everybody else, pharmacies, family doctor, and that's sort of going to be our distribution mechanism. So I really encourage everybody to get one of these vaccines sooner rather than later. And then again, from a COVID-19 perspective, we will see, as I mentioned, the number of tests keep going up, but right now we're experiencing actually like a bit of a delay in the lab to process those tests, but you can, book your testing if you have any symptoms through 811 or this online assessment tool, and then get My Health Records to get your results very fast. And so that, I think, is all actually I have. So thank you very much. And maybe I should answer some questions, or what's up?
So thank you very much, Dr. Hu, for that comprehensive overview, particularly really showing some of the updated epidemiology and from a public health standpoint. Excellent, excellent. Great presentation. We do have quite a bit of questions, stirred some conversations. So first it would be, do you anticipate fewer cases of influenza due to the use of masks this year?
Yeah, I think there will be. I mean, it's hard to know like what the baseline number of cases you have will be, because in any given year you can have a lot, like there's a range, right? Let's say in a year you might have anywhere between like 50 and 150 cases. I do think that we would have less than we would have had if it weren't for the things we've done, like the masking, like the physical distancing, right? And certainly even in Alberta, right, where things remain very open, there's not like, there's just like fewer interpersonal interactions. So there should be less. I mean, it's hard to know what the counterfactual is. And it's also hard to know how much less, right? And so, is it going to be like 5% less, 50% less? We don't know, which is why I think it is really imperative that we continue to take precautions, against both flu and COVID. And the one additional thing we can do for flu is get a vaccine.
Great, excellent. Another question we have here, are HEPA filters effective?
They're okay, is what I'll say. There's like some marginal utility to having them. I have a little review on HEPA filters I can share with you guys if you want after, or like filtration systems. I do think actually, like when you think about, and it depends on what setting, right? So in the airplanes, they have HEPA filters, but they also circulate the air 20 times an hour. And like which of those is more effective, or like which contributes more? Like, I'm not sure, but there's probably some marginal utility to it. If the question is, do I need a HEPA filter? Like if like in my home, like probably not. Say, if you have a case of COVID in your home, the best way to not get COVID from that person, your household contact, is to just like not, for if possible. In facilities, we've been thinking about this a little bit, but I think the best way there is to just like jack up your air circulations if feasible from a sort of facilities like flow perspective.
Great, thank you. We have a question here from Jenny. If Alberta compares itself to the rest of Canada by per capita, Alberta has as many cases as Ontario and Quebec. So why does Alberta not add more restrictions in select areas?
Oh, that is a good question to ask Jason Kenney. I mean, to be clear, right? Like all the big decisions around what we should do around closing, reopening are made by cabinet, right? And I think people like Dina Hinshaw, like they advise for sure. And I think, she does have the trust of, the politicians, but, I also think it's right in some ways that like, it's our elected officials to make these decisions. Like we voted for them. I mean, and so like they essentially bear the responsibility of making big societal decisions. So yeah, that is a question for Jason Kenney and crew.
All right, another great one here we have is there a risk that there will be a shortage of flu vaccine this year?
Good. I don't know, right? So we have sourced more flu. Again, this year, like flu vaccine demand is remarkably stable from year to year, right? Like it's just always around 30%. This year, I think they've sourced enough to like cover enough flu vaccines for about 45-ish% of the population. And so the question is like, how many people like will get the flu vaccine? And, I think there's going to be a jump because of the COVID, but we don't know how much. I think in figuring out how much to source, modeled a little bit for, demand and whatnot. So I hope not. That being said, like, I just like, as it applies to our personal lives, like, I mean, you can just go to a pharmacy and get one. Like, I think the earlier you go, like the more protection you'll have over a longer period of time, which is a good thing. And then you'll have a flu vaccine as opposed to waiting till January, which would be sort of weird anyways. But anyways, yeah.
Great. And just finally, testing is highly available, but the analysis is slow. Why is that?
Yeah, so when we think about like total turnaround time, and I'll define total turnaround time as the time when you like go online and book your appointment to the time when you receive your lab result. I decompose that into a number of factors, right? So one of that is like how long it takes you to be booked into one of the testing centers. And after that, it gets sent to the lab. And the other big chunk is like how long it takes the lab to run the test, right? And then lastly, it's like, once the test has been run, how long does it take for the results to be reported to you? So at different times during the pandemic, the assessment center backlog time has been higher and lower, right? But now it's pretty, like 3 weeks ago, it was like 5 or 6 days to book an appointment at the testing center. Now it's like 1 or 2 in Calgary, so it's pretty good. So we try to modulate capacity to demand. Right now, the lab is getting hit by tons of tests. And so that's why we have a delay there. We've had delays in the past. Every single delay like we've encountered, we actually, like the people who run the lab and the people who run the testing centers are very good. Like they're quite good at like flexing capacity to demand. What's essentially happened, like, but they can't do it overnight. And so, you know, throughout the summer, we'd offer testing to all Albertans, whether they had symptoms or not. And our demand was, let's say, lower than it was in September when schools opened and people were just like more keen on getting tested. And so like, yeah, like it'll get better, like it always does, right? Like they're very good at adapting, but in the meanwhile, it sort of like slows things down.
Great, great, thank you. And I do appreciate there are some additional questions here, but we will move on and perhaps we can get to them during the panel discussion later. So at this point, thank you again, Dr. Hu. I would now like to welcome and introduce Anjli Acharya. Anjli is a pharmacist and independent clinician specializing in vaccines and travel medicine. She's the past president of the Alberta College of Pharmacists and the Canadian National Association of Pharmacy Regulatory Authorities. Today, she will let us know what to expect this immunization season, what immunization you need, and how to get immunized. So I'll pass it over to you.
Thanks, Mealy. So I'm going to bring my screen up here. Oh, I'd like to share. I think everyone should be able to see my screen now. So I'm happy to be talking to you today, and you know, it looks like we're going to be taking a bit of a side turn. Dr. Hu and Dr. Szabo did a great job of reviewing all of the little details around both immunization and coronavirus and what we're facing this year. There will be a bit of overlap around the influenza vaccine. However, I think that it's important to sometimes hear these things twice, even from different presenters, so that you can really absorb the information. So I'll just move through the presentation as normal, and I hope you can forgive some of the duplicate. But what we're going to be looking at today is adult immunizations, and all adult immunizations that we need to be considering, not just in the context of influenza season. So there's generally four important vaccines in adulthood. So there's influenza, there's pneumonia, there's shingles, and there's our tetanus vaccines. Now, adults need vaccines, and that's often a surprise for a lot of people, but there are vaccines that we should be getting in adulthood, and they protect us, they protect the people around us, and they overall reduce our risk. So in particular interest this year is influenza and pneumonia vaccines, which comes as no surprise because overall they will reduce our respiratory or lung-related risk factors if we have them up to date. So I'm looking forward to moving through all of these vaccines with you. I'm providing you with some practical insight as to where they can be received, and happy to answer any questions, but we do have quite a bit to go through for a short period of time, so I'll move through it the best that I can. Before I jump in, you have heard the word NACI earlier today, and what NACI is our National Advisory Committee on Immunizations. And what's interesting is that in May 2020, they recognized that older adults are particularly susceptible to severe outcomes of COVID-19 and are at higher risk of vaccine preventable diseases overall. And they made a specific guideline recommendation that our older adults, in addition to pursuing all of the preventative measures you've heard about today, should be also looking at their pneumonia vaccine, their influenza vaccine, as well as their herpes zoster. And herpes zoster is another name for the shingles vaccine. They also made a point of saying that that we want to try to ensure that all of our older adult interactions for vaccinations occur at the same time. So overall, they wanted to reduce the total number of healthcare interactions that our older adults are having, so that we can reduce overall community transmission and COVID-19 risks. So don't be surprised this year if your physicians, your pharmacists, the nurses in your life are all asking you to get more than just the influenza vaccine, and are asking you to think about the other adult immunizations that are available to you, because it's important that we ensure that all of our vaccine preventable diseases are addressed. We've talked a bit about how influenza persists on surfaces, and COVID-19 and influenza have a lot of overlapping symptomology. So it's going to be challenging this year to really identify what's going on. So whether that's influenza or a cold or COVID-19, we find ourselves in a situation where it's going to be further complicated because they share so many critical symptoms. And our older adults overall have a higher risk simply because of the natural accumulation of medical conditions that they have as we get older, things like diabetes and heart disease and immunosenescence, which you also heard from Dr. Szabo and Dr. Hu, which is that natural reduction of our body's immune system and inability to fight off severe infection and have a strong immune response to vaccination. So that's particularly important because as we get older, our symptoms, or the symptoms that we show when we get diseases like influenza, actually become less present. So while we can still have fever, it'll be milder fever. It'll be possibly no fever as we get into the ages of 85 plus. And so it becomes much more complicated to try and determine what in fact an adult is experiencing when they are experiencing some symptoms, if they're experiencing symptoms at all. And it's much harder to tell if they've actually in fact got influenza. So since we have a vaccine, it makes far more sense for us to ensure this year more than ever that everyone is vaccinated against the influenza vaccine. And you've seen this slide, but again, it's not just the respiratory symptoms that people get when they get the flu. There's so much more to an influenza vaccine that extends beyond a typical cold. We've got an impact on the heart, on our other organs in our bodies, as well as diabetes, can all be negatively impacted. And as you heard before, it can even lead to heart attack and stroke type symptoms because of that influenza or that inflammation, type impact that influenza can have on the human body. So the net result is that we'll end up with more hospitalizations for seniors over the age of 65. And really, even though seniors, people over the age of 65 are about 17% of our Canadian population, they make up the vast majority of our hospitalizations due to influenza A, particularly on years that we have a particular type of influenza A circulating. So I'm really hoping that this year that will not be the case. Our influenza targets, we haven't been able to meet them for several years now. We hover around 70%. And I think it's incredibly important that we all work together this year to ensure that, particularly in our high risk patients that are age 65 plus, that we're encouraging you and you're encouraging your family members and people around you to get their flu vaccine so that we can all be better protected. Remember that NACI organization that Dr. Hu mentioned, and this is a similar slide to the one that he had. These are the guidelines that were put out with NACI, and NACI is an unbiased organization that presents data and recommendations for individuals and public health. So what makes this interesting, and another way of saying is that public health level decision-making by NACI is a recommendation to our provinces who make these decisions as to what types of vaccines would be recommended. And they recommend that any of the available influenza vaccines approved in Canada this year is a good choice for preventing flu. However, NACI has also made individual level individual level recommendations for the flu shot this year. And what they've said is that the high dose flu should be used over the standard flu vaccine for individuals over the age of 65 if they so choose, because it has been shown to be more effective overall. So that means at an individual level, the high dose flu vaccine has that evidence, as what Dr. Hugh had said, but the challenge is that it's not covered by public health. So the real take home here is that if you want to have that high dose flu, there will be a cost associated with it. And I'm often asked what that cost is, and that cost runs about $70 to get that high dose flu vaccine, but it also deals with that immunosenescence that we were talking about, that natural reduction in our body's ability to mount a strong immune response to vaccine. In fact, we know that adults over the age of 65 have up to a 50% reduction in immune response to the standard influenza vaccine as they get older. So compared to the people that are younger than 65. So we really want to ensure that those people who have the ability to have a stronger vaccine that's going to work better for them have the ability to do that. But if they can't, and the public health vaccine is available, that is also more than reasonable. The reason why the high dose flu vaccine is recommended, and again, Dr. Hugh reviewed that, is because it has been shown to have a higher immune response in our adults over the age of 65, because it has 4 times the amount of the immune triggering antigen or the immune triggering product inside the vaccine that will allow the human body to have a stronger immune response and therefore have a stronger impact and overall improves the efficacy of the vaccine. But the fact is that we can get standard flu everywhere. Our pharmacies, our doctor's offices will be able to provide the standard flu vaccine this year. And it is available free of charge. The high dose flu is available also in quite a few places. It does have a cost associated with it. This year, the federal government allocated several doses of the high dose flu to anyone over the age of 65 in long-term care facilities across Canada. And so we know that seniors over the age of 65 in long-term care facilities will be receiving high dose flu in Alberta. I get a lot of questions around, if I'm over the age of 65, but I live in the community, should I be getting high dose flu? And our national guidelines would indicate that it is going to be a more effective flu shot, but recognizing that it'll also come with a cost. So we do need to make those decisions individually and have those conversations with our healthcare professionals. So just talk to your pharmacist, talk to your doctor, but above all else, get a flu shot. They both work. It is better than getting nothing, and I highly recommend that you get your flu shot this year. So moving on, I did want to take some time to look at pneumonia or pneumococcal disease today, because, you know, as a clinician, when I'm talking to individuals about the flu shot, I can't not talk about the pneumonia vaccine. They go hand in hand. Who here, I wish I was in a crowd with you, but I would ask you who here knows anyone who's had pneumonia, and the vast majority of people would normally have known someone who has pneumonia. And those of us who know someone who's had pneumonia knows that it's more than just a cold. It's a very significant condition, and in fact, pneumonia and influenza together is listed as one of the within the top 10 causes of death in Canada. So pneumonia is a significant infection of our lungs. Influenza is commonly the gateway that opens up the doors to that serious invasive pneumonia. And it causes a lot of inflammation in our lungs, which then limits our ability to absorb oxygen and has a significant impact on our overall ability to recover. So when we look at the risk factors of pneumococcal disease, you're going to see that this list is very long and somewhat complicated. And what I want to assure you or reassure you is that your pharmacist, your physician, your public health nurse, they know this list very, very well. So whether it's chronic disease or heart disease or diabetes or being a smoker, these are all things. If you're on this list, it's time to ask the question, do I have my pneumonia vaccine? Ask your family doctor, ask your pharmacist. You know, there are certain conditions like this that will increase your risk of pneumonia, but there's also behavioral things like smoking or alcohol use, or external things like where you live. So we know that long-term care is a risk factor, or having a previous case of pneumonia can increase your risk of getting pneumonia in the future. But most importantly, I want you to notice that in the middle, people over the age of 65 alone, without any of these other external factors, are at increased risk of pneumonia. So much like influenza, the medical conditions that you have actually can significantly increase your risk of pneumonia as well. And the take home here is that if you were to just be over the age of 65, or if you were under the age of 65 with a medical condition, your risk can up to double, even just because you're older than 65. So even if we've had diabetes, since we were 55 years old, as we approach the age of 65, our risk increases simply because we're getting older. And it's not just with age. We know that these diseases can have a significant impact. So obesity, being a smoker, diabetes, stroke, heart issues, and COPD is congestive heart failure. COPD is a significant impact on overall pneumonia risk. So it's important to note that COPD in particular is one of our highest risk categories for pneumonia for being hospitalized. So it really doesn't matter how old you are. It's important to be paying attention and choosing to pursue vaccination. So when we look at NACI again, that amazing committee of unbiased clinical experts, they do make a recommendation that on an individual basis, and again, that individual basis again, that immunocompetent adults aged 65 years and older should be immunized against pneumococcal disease. Now, in particular, they're talking about the pneumo 13, or otherwise known as Prevnar vaccine, and then followed by the pneumo 23, which is known as Pneumovax, for the prevention of pneumonia. So this is a high-level recommendation, and what you've noticed is that there are two different pneumonia vaccines available in Canada. So there is a pneumonia vaccine, the Pneumovax 23, which covers 23 types of the pneumonia bacterium, and then there is the Prevnar 13 that covers 13. Now, you may be wondering what the difference is between these two different vaccines. One is called a polysaccharide vaccine and one is called a conjugate vaccine. And I guess the easiest way to say this is that a polysaccharide vaccine is our original technology. It's the technology that we have used and we have used for many years. We have several serotypes covered under it, and we continue to see it used regularly by public health. The pneumococcal conjugate vaccine is a newer technology. It's a more effective vaccine. It mounts a stronger immune response overall. And we're going to continue to see development, I think, of the conjugated vaccine variety in this area. So we know that the Prevnar 13 vaccine causes a stronger immune response overall, covers 12 of the same serotypes, but it has one that's unique to itself. So basically, the conjugate vaccine, or the Prevnar 13, is simply a better immune stimulating vaccine. So they're currently they both have a role in guidelines around prevention of pneumonia. Now, this is going to get, I'm going to warn you, this is going to get a little bit complicated, but I hope that I wanted to make sure that you had this little piece of information because it's practical and it's important for you to know what the thought process is when you arrive and talk to your healthcare professional about needing your pneumonia vaccine. So when we look at the pneumonia vaccine, it is important to take home that any senior over the age of 65 who has never had a pneumonia vaccine, it's easy peasy. All you have to do is come in, you haven't had your pneumonia vaccine, you're going to get your Prevnar 13, you're going to wait 8 weeks at least, and then you're going to get your polysaccharide pneumococcal vaccine 23. It's that simple, okay, if you've never had it before. And your healthcare professional, trust me, knows all of this. So all you have to ask them is, do I need my pneumonia vaccine? And they can help you answer that. Now, the little bit of a challenge is if you have already received your pneumo 23 or your pneumonia vaccine from public health, it really depends on how long ago you had that vaccine. So you need to wait at least 1 year before you can get that other pneumonia vaccine. It needs to be at least a year longer. So people will often ask me, why the 1 year? Why the 8 weeks? And it's an easy answer. The reality is that the Prevnar 13 has been shown to have a stronger immune response if we give it first. So we've tried out all the combinations, and what we know is that if we give you the Prevnar 13 first, or the pneumococcal 13 first, then we follow it with your polysaccharide vaccine in 8 weeks, we're going to get a better immune response. Now, that doesn't mean anyone who's already had their polysaccharide vaccine or their original Pneumovax vaccine is at all needs to be worried. It just means that we do know that there's a better way, and that's reflected in our guidelines. And if you've already had it, the goal is to wait at least a year so that we can ensure that you get as strong of immune response as possible. So when we look at this, it kind of becomes clear as how do I decide if I need my pneumonia vaccine? But there is a unique group that we do need to be aware of, and those are the ones that are immunocompromised. So those are the individuals that have cancer or are facing or taking drugs that will reduce the impact of their immune system or their ability to fight infection. And we call those individuals immunocompromised adults. And in those individuals, we're going to want to give them a booster dose of their polysaccharide vaccine after 5 years. Now, the age at which you're getting these vaccines do matter. And so, like I said, don't worry about memorizing this flowchart. What you want to do is know that if you have your pneumonia vaccines, and whether you're going to ask your pharmacist or your doctor about ensuring that they are fully completed, that you have had all the pneumonia vaccines that you need to have. Now, the Prevnar 13, like the high-dose flu, does have a cost associated with it. It's approximately $150. And then the Pneumovax 23 is the free vaccine. They put the little green sticker on your healthcare card and puts the date on it. That's the free public health Pneumovax 23 vaccine. So that'll give you a bit of a clue as to which ones that you've had. The other thing to make things a little bit well, it's actually quite positive, is that Alberta Health has actually increased the availability of the Prevnar 13 vaccine for special groups. So individuals that have certain medical conditions that put them at higher risk. So I would encourage you to talk to the healthcare professionals that are well aware of these guidelines so that they can support you in not only finding out which pneumonia vaccines you need, but also whether you can have them covered or not. Okay. Moving on to shingles, because we have 2 more to get through before we finish up today. So typically, what I'd like you to be aware of with shingles is that it is a reoccurrence of the chickenpox virus. So shingles will impact about 1 in 3 individuals in their lifetime, and you saw that with NACI, they call it herpes zoster, but it's in essence most of us will call it the shingles vaccine. So anyone who's had chickenpox is at risk of getting shingles, and that risk increases sharply after the age of 50. So we really do start to see the use of the shingles vaccine at the age of 50 plus. Okay. Now, we can do something to prevent shingles, and there are 2 different shingles vaccines. The first is called Shingrix, and the other is called Zostavax 2. And really the take home here is that Shingrix is the recommended vaccine for anyone over the age of 50, and it is 2 doses. Many people don't realize that it's 2 doses, so if you've only received 1, you do need to get your second one. And you have to have waited at least 1 year if you had a shingles vaccine prior to Shingrix becoming available. So it needs to be at least a year ago before you've had it, or you would have to have had, if you've had a case of shingles, you need to wait at least a year before you would consider having the shingles vaccine. So generally, Shingrix is considered a more effective and safer vaccine across all age groups. And right now, immunity has been moved up to 5 years, but yeah, 4 to 5 years is reasonable. Okay. The only time Zostavax is recommended now is if a Shingrix vaccine is unavailable, or if an individual's had a reaction to it. So vaccine availability is at all pharmacies. Unfortunately, Shingrix is not covered, so you'd have to check your personal drug plans to see if it's covered, and certainly your pharmacist can support you with that, or getting a prescription from your family doctor to get that vaccine completed. But there is value in getting your shingles vaccines done, because shingles is the type of disease that I like to call it the kick you when you're down disease. When everything's not going well, that's when shingles tends to appear. And it's unfortunate because that's exactly when we're not thinking about these types of preventative measures. So the goal is to actually think about these preventative measures before we find ourselves in situations in our life that are going to stress us to the point where our immune system can no longer keep that virus suppressed. So our final vaccine that I wanted to review with you today is the tetanus vaccine. So we think tetanus, it's the one that everyone knows, but it's important to recognize that it's not just for a rusty cut or a cut at all. It's a vaccine that we should be getting regularly into adulthood, typically every 10 years. What we do know is that persons ages 60 years and older are accounting for up to 48% of our cases of tetanus, and 59% of those cases are men. So these are the grandpas and the dads, and I have them. I have grandpa, I have a great grandpa, I have a dad, and they're out working in the garden and they get a cut and they're tough and they just hold on to it until it stops bleeding and tell you they're fine, right? And I say, did you have a tetanus? When was your last tetanus? And they can't remember. And so I would encourage you that whether male, female, or not, you should really be thinking about ensuring that your tetanus is up to date. So any kind of significant dirty wound is a risk factor, but having it up to date means that you can just clean that wound and get on with your day, right? We also know that those that were born out of country, that weren't born and raised in Canada, have a higher risk of not having adequate immunity to tetanus. So it's also important that if you have family members or friends who are newly immigrated, that you encourage them to go in and get their tetanus shot done, their tetanus shot updated. Now, a lot of people don't realize that the tetanus vaccine is a combined vaccine. So it always comes with diphtheria. So when someone says you're getting your TD vaccine, it's because it's a combined vaccine. It's also combined with another vaccine, which is pertussis, or more commonly known as whooping cough. So the combined tetanus, diphtheria, whooping cough vaccine is a unique vaccine. We call it a Tdap. And the reason why we have it is because we've actually had several pertussis outbreaks here in Alberta over the years, as you can see them listed down here on the side, with the most recent being in 2017. And what we know about pertussis is that cases are primarily in our newborns, our infants, and they're the most at risk because their lungs aren't fully developed enough to deal with the infection, and it's and adults over the age of 60. So while the disease can be mild, it can lead to pneumonia, but it also can transmit to our high-risk infants, which we just really don't want. So it's important that if you have new grandbabies in your life and you have new infants that you're hoping to have an opportunity to visit, that you have a tetanus with a whooping cough updated at least once in your adult life. So tetanus every 10 years, but at least once in your adult life, you want to have a tetanus with whooping cough updated, particularly if you're going to be around newborns. Okay. We do have additional boosters for pregnant women, but that can be done in the pharmacy. So when we look at tetanus vaccines, we can get our plain tetanus at pretty much every doctor's office and public health facility. We can get our tetanus with pertussis. Is a little bit more challenging to get as wildly as the tetanus, plain tetanus. However, you can get the tetanus with whooping cough at a cost at your pharmacy or doctor's office, or if you contact public health and they're able to verify that you haven't had one in your adult life, they'll provide you one as well. Now, so it's a challenging one, but it's important as a part of our adult immunization vaccines. It's not top of mind, but it's something that we should be ensuring that is up to date on a regular basis. So our key messages today are that adult vaccines are safe and effective way of preventing life-impacting and life-threatening diseases. And it's really important that we are all maintaining our adult immunizations. Our key vaccines in adults are influenza, tetanus, diphtheria, pertussis, known as whooping cough, pneumonia, and shingles vaccines. And these vaccines, we can help you get them, and we should be getting them all at the same time. So if you can, contact the healthcare provider that you have the best relationship with and ask that you want to not just get your flu shot, but you're hoping to review your other adult immunizations to ensure that we're limiting the number of visits that we're having, and we're making sure that we're getting all of our vaccine preventable diseases updated at one go, because they can be given together. So, and that is all today. I'm happy to answer any questions.
Great, thank you very much, Anjli. It's a very comprehensive overview in terms of all the immunization. I'm sure a lot of food for thought for all the attendees. I know Dr. Hu did try to address some of the questions in the chat box, so thank you, but I will ask a few of them perhaps you can shed light on. One question is the pneumonia vaccination only available once you are 65 plus?
So I can answer that one, Mile.
Great.
So the pneumonia vaccine is a, I'm actually going to turn off my share, then you can see my face, right? So the pneumonia vaccine is an interesting vaccine because the recommendation is that everyone over the age of 65, 65 itself is a reason to get your pneumonia vaccines up to date, but there are other medical conditions that will increase your risk of pneumonia, and therefore are reasons to have the pneumonia vaccines. So you can have it at the age of 65, but there's certainly other medical conditions where people will have been offered or will need their pneumonia vaccine prior to the age of 65. In fact, the conjugated pneumonia vaccine is currently approved for everyone from 6 weeks to as old as they get. So it's covered for everyone. So it's just a matter of talking to your healthcare professional and determining if your risk factors put you in a position of getting your pneumonia vaccine.
Great, thank you. And just one more, is it necessary for a shingles vaccine if you've already had shingles?
So what we know about shingles, the particular disease state, is that people can have reoccurrences of shingles. And as they get older, their ability to keep that virus from reoccurring actually starts to go down. And so having an outbreak of shingles doesn't necessarily mean you're not going to have another outbreak of shingles. So we recommend that anyone who's had a case of shingles still pursue getting the shingles vaccine as long as it's been 1 year since they've last been infected.
Dr.
Great, perfect.
Would you mind if I asked a quick question of
Sure.
because of I thought it might be of interest to some of our seniors as we go into the winter months and become isolated, regardless of whether it's due to COVID or whether it's because lack of mobility in winter months. For older adults that would like to have their immunization but can't get to a pharmacist or can't get to the clinics. Kerby Center had a flu clinic just recently, but for those that cannot get out, are there options for them to be able to get their immunizations at home?
So when we look at the challenges of accessing the flu vaccine, so today is in fact the first day of influenza season, and I know from my pharmacy colleagues that everybody is taking a deep breath and jumping in and looking to provide the vaccine in the safest way possible. I reviewed several of the corporate web pages on actually booked appointments, and they're booking 3 weeks out at this point. So, and we don't see the walk-in availability as we have seen in the past. So that is going to be a challenge. I would encourage seniors to talk to their family members and get those appointments booked, get individuals who might be able to take them in. Organizations like Kerby Center or long-term care facilities or assisted living facilities are contracting out to clinicians to bring vaccine on site to provide a single flu event within a building to try and access those seniors that can't leave their buildings as easily. But I would encourage everyone who is in a position of being unable to get their vaccine to talk to the individuals who are administratively involved to support them in ensuring they can get the flu vaccine. But I have not heard of anyone who's actually doing home visits to give flu vaccines at this time.
Thank you. That's good information. Try and follow
Great.
up with members.
Great, thank you. And just lastly, Anjli, for the pneumonia vaccine, is it once in a lifetime or taken periodically?
So once you've had the 2 different types of pneumonia vaccines after the age of 65, you're done, unless you have a medical condition that reduces your immune system. And of course, talk to your healthcare professional about that, and then you may need a booster. But yes, once you're done, after the age of 65 and you've had both, you're done.
Great. Thank you for that, Anjli, for addressing all those questions. And I'm just being cognizant of time here. I believe we're a little bit over, Colleen, but one question did come in early that perhaps I can get everyone's opinions from all our panelists, because it is a great question, especially with Dr. Hu discussing a little bit around vaccine confidence and some of the data from that Angus Reid report. The question is, I have relatives and friends who are naysayers. How do you suggest a person should respond to them? So I think it really touches on vaccine confidence and advocacy. So I will pass it over to you first, Dr. Szabo. You're on mute, Dr. Szabo, sorry.
Can you guys hear
There
me
you-
now?
Yes, yes.
That question is actually not surprising. We actually have patients in our clinic who sort of say, you know what? I am not sure whether I'll get the COVID-19 vaccine because it is so much expedited and it takes such a short period of time for FDA to approve it. So how good it is. And I can certainly understand from their point of view. So it's not like the influenza vaccine in which there's a lot of time and effort which is put in to make sure that the safety of the vaccine is there and that it is effective. We know what kind of a viral particle which can induce a very, very good a good response. COVID-19 is such a new disease. There are currently, I would say, more than about 30 vaccines in the development, and there are different ways of developing the vaccine, the RNA base and the DNA base, and you name it, okay? But the thing is, we really do not have clear data of how effective it is. And also the particle that they use induce what kind of antibody which will be helpful to the patient, we don't know. However, if there's something which is available based on the lab that if I give you that vaccine, it will increases your immune, you have a good immunogenicity of this particular antibody. And a lot of the vaccine company also do further study in terms of making sure that the antibody is effective. Yes, it is quick, but it's better than nothing. All right. I predicted that, they would approve the vaccine very quickly. And you just have to wait for the literature later on to do that. So it's a personal thing. Some people would say, over my dead body, I would not take it. Some would sort of say, the vaccine is a holy grail. But what I worried about is people think that the vaccine approved is a holy grail and they let the guards down in terms of personal protective. And they can go out and do partying, they can do whatever it is before we know how effective the vaccine is. So that's my take. So
Great, thank you, Dr. Szabo. Same question, Dr. Who? Perhaps some public health perspectives.
Yeah, I know. I mean, I think people have a lot of concerns about a number of factors. And to be clear, right now, we don't know if there will be a effective vaccine. I'm not sort of confident there will be based on some of the early phase 1, phase 2 studies, but we're waiting for phase 3 data, which really lets people know whether or not it works. So right now, I'm not wouldn't recommend people get a COVID vaccine because there is no COVID vaccine yet. I do think though that let's say there is a COVID vaccine available, and let's assume we should hear pretty soon, actually, what do we do? When it comes to this issue, it's not that, I think if you think about vaccine hesitancy, there's hesitancy around childhood vaccines, which is quite low, actually. Those are the people who think MMR causes autism. There's hesitancy around flu vaccine, which is, I would say it's its own bucket because of different reasons why people don't get flu vaccine. And there's hesitancy around COVID vaccine, which again is its own bucket, again, driven by sort of the pace of development, lack of long-term safety data and some of those factors. And I mean, I think that if I were to sort of articulate things to patients with concerns right now, what I would probably say, and I will say this, right? One of the most important things, in vaccine hesitancy land, probably our best intervention to improve uptake is a recommendation from a trusted healthcare provider. So when, Dr. Mary tells people you should get a flu vaccine, that definitely increases the chances of that happening. Or when Anjli tells people you should get a pneumococcal vaccine, that definitely increases the uptake. For now, I would probably say, in the time before we have an effective vaccine or really the phase 3 data, I would say, yes, the vaccine was developed quickly, acknowledge that. But Health Canada is not going to approve something that isn't safe. And I think, what happened is in the US with Trump basically trying to co-opt the CDC and the FDA, and the FDA approved stuff in the US. I mean, and that's really diminished confidence in the institutions that we would normally trust to approve things. And, you know, I would say for now, it's just like, yeah, like it was made quickly. But, you know, we've taken these safety steps. Health Canada is, I mean, traditionally they have been relatively slow actually, and this might be to their advantage this time around. But yeah, they're not going to approve something that isn't safe. And then, you know, to Mary's point around like relaxing your guard, like I agree in that, you know, whether or not you can do, like in the ideal world, like what I want the world to go back to what it was like before, right? For that to happen, you need a vaccine with a certain effectiveness and a certain, and once you reach those levels, the world can go back to the way it was before. But until then, we can't, and we sort of do need to take some of these precautions. But maybe I'll frame it differently. You know, like I normally, like my day job before COVID was to like think about vaccine uptake for the province, and you know, it certainly would be very troubling to hear people, oh yeah, MMR causes autism, but you know, like no person has died of measles in this country for many decades, right? Even with all the stuff around vaccine hesitancy. This, I mean, I would say vaccine hesitancy on flu leads to a lot of deaths, you know, every year, actually, frankly. But for the first time, maybe we have this vaccine that if it works, if people don't get it, will lead to thousands of people dying. And our economy, which is a federal deficit, $350 billion, which is pretty high, lots of people losing their jobs. And so, you know, the consequences of people not being immunized are just really, really high. In Alberta, it will not be mandatory for anybody, based on my discussions with Dina. And so it really is us trying to convince people that, you know, if there's a safe and effective one, that we should get it. And I'll just, you know, and like part of the work I'm doing now is really like you do a bunch of surveys to really understand like what makes people worried, addressing what messages work. But I would implore everyone on this call, like, you know, like once you have the data, once Health Canada approves, you know, talk to your doctor, talk to your health provider, but like don't not get it because you think COVID is not a big deal, because that's what we've heard from, you know, some of our respondents, right? Like don't not get it because you think Health Canada has been co-opted by Trump, because that's not the case. Like it, you know, it's going to require quite a, you know, societal effort to get this through. So I talked for too long, I'm sorry, but it's it is the you know, it's our only way out of this, I think, and I hope we choose to take it.
Great. Thank you, Dr. Hu. And lastly, I will pass it over to Anjli, perhaps getting some experience on vaccine confidence in general around immunization, just through based your experience and the education you've conducted with patients in the past. Oh, sorry, you're on mute, Anjli.
Second. There we go. Thanks, Millie. You know, it's interesting, vaccines and immunizations. I've worked in the field of immunizations, providing one-on-one discussion with patients over 12 years now. And so I've seen all the discussions and all the arguments and all of the issues around vaccine hesitancies over my career. And what I can tell you more than anything is the importance of taking the time to have the conversation with each other and with healthcare professionals who are very clear and very aware of the data and the research that's out there. And I find that for the vast majority of patients that I've had the pleasure of working with, after we've had the opportunity to have the discussions and understand the risks and understand the importance of prevention, the vast majority will choose to move in that direction. So when it comes to the COVID vaccine, I strongly believe that as we move in that direction and have one made available and the data becomes available and the type of vaccine becomes available, experts in the field will be able to have conversations one-on-one with patients to improve our vaccine uptake and ensure that the public as a whole is better protected. So I'm quite hopeful that even though the surveys are saying what they're saying, that we'll move in the right direction, because we have managed to do that with every other public health vaccine for the most part.
You know, Molly, I'd like to make a comment on what the other two speakers say. In any products, like even Apple, there are people who are early adopters. They will line up a week before to get the newest iPhone because they are early adopters. They truly believe in the products, okay? However, there's some who are late adopters. They want someone else to try it first to make sure that it works. And so in every single cases of whatever vaccine or medicine that you actually, you know, pick up and say, this is working for certain certain disease, there are always a proportion of people who would say, I'm in for that because I truly believe in it, okay? And vaccine is no different. But it seems like vaccine compared to any other drugs is because you have a lot less early adopters than late adopters because people have a lot of myths about vaccine in general, okay? Number one is the vaccine doesn't work, okay? Vaccine causes disease, vaccine causes autism, or vaccine, it's better for me to get the natural infection than to get the vaccine. So all these myths about the vaccine have to be debunked by the physician when they talk to them about it. So I have someone who would say, forget it, Mary. I would want to get the disease than to have any foreign material injected in my body. And they fail to understand that that organism which hits you is a foreign body. So there are lots of myths. And if you want to increase vaccination rate, the physician has to spend some time with the patient, address the concern, debunk some of the myths, and go forward. Personally, if there's one available for COVID-19, I will be going for it. Okay, because I truly believe that it's better than zero. The efficacy might be a little bit low, but as Dr. Hu say, these guys have studied a lot of safety thing, and they halt the study in the phase 3 study, even if they have 1 or 2 adverse effects, they put the whole thing on hold. So we have to have some kind of trust with the vaccine company that they are doing the right stuff and they will make vaccine which is safe for us. We don't know whether it is effective or not, but the safety issue, we do have to have some trust in the company. So.
Great, thank you for that, Dr. Szabo. And again, I'd like to thank all the panelists for their perspectives and insights. Extremely helpful, and I'll pass it back to you, Colleen.
Thank you so much, and I appreciate that we have gone over time, but I can tell you that we've retained the majority of our attendees, our guests today, so clearly they were interested and appreciative of the information that you were imparting here today. So thank you all very much. Great information. I know that I, for one, have learned a lot, and I see that we do still have some questions. We're getting some great comments in here as well, people that have appreciated the information and thanking us for such a wonderful presentation. So I'm going to do a quick little screen share and just kind of move quickly here as well. There, and so I'm just going to go through quickly here so that I can provide this information to everyone, just to make sure that everyone is aware the Kerby Center is now open and offering our critical services for you, including a pop-up free bread market on Fridays and free mask distribution. So if you need any of our services at all, information is here for you. As I started to say there, we have some questions that were still coming in. I will follow up when this is after the presentation, and we will get the video up on our YouTube channel, and I will be sending you out messages to let you know when that is published, and we can be sure to provide contacts for each of our doctors to provide any further information for you if you need. So just feel free to email the email address that you got with your links. And I'm hoping that you've enjoyed today so much that you will enjoy us next presentation, our last presentation in this series, October 30th, when we will have Dr. Patrick Mitchell, who will be joining us to talk about lung health and respiratory infections. Dr. Mitchell is a clinical assistant professor of medicine at the University of Calgary, and he'll talk about a little bit further about some of the information you've heard today about how pre-existing conditions with your lung health and infectious disease can be a problem for older adults. So registration is free at Eventbrite, so we hope to see you at that one. And then we have other upcoming presentations presentations, financial wellness, wills and estates coming up. Remembrance Day kickoff week with President of Valor Canada to talk about the soldiers of the Fighting 10th who were from Calgary during the First World War. And then we are jumping ahead here, that Kerby Centre has traditionally had a large live Remembrance Day service in our auditorium. And of course, this year we cannot do that, but we do want to continue our long-standing tradition to honor our military and fallen heroes. So we will be holding a small event that is just private, but we will be live streaming that event. And so that again will be registration on Eventbrite, and we'll provide the links for the live stream. And looking ahead to a very merry and safe, small, distanced version of our members' luncheon at Christmas time, working toward those plans. And again, I would just like to say thank you so much to Sanofi Pasteur and all of our doctors today for such a wonderful presentation. And Dr. Stanochik, thank you so much for moderating for us today. That was wonderful, and we'll look forward to being able to share that video with each of you as well. And again, just to let you know that the online sessions are free of charge and donations are appreciated to Kerby Centre to help to keep our outreach programs going for supporting seniors in their homes. And if there is nothing further from anyone, I think that we can call this a very well done wrap. Thank you very much to each of you, and we'll look forward to seeing and working with you again in the future.
Thank you for having us.
Thank you.
Thank you, Colleen, and thank you
Yeah.
everyone for attending.
Thank you, and you all stay safe as well.